Hey, CE Impact subscribers, welcome to the Game Changers Clinical Conversations podcast. I'm your host, Josh Kinsey, and as always, I'm excited about our conversation today. Respiratory syncytial virus continues to cause significant illness in infants, older adults, and high-risk groups, making recent advancements in prevention more important than ever. In this episode, we'll break down the current landscape of RSV vaccines and monoclonal antibodies so that you can confidently support immunization efforts across pharmacy settings. And it is great to have a longtime friend, Kaylin Manasco, as our guest for today's episode. Kaylin, it's so good to see you. Thanks for being here today.
Thank you for inviting me, Josh, and it's great to see you. We had a few minutes to catch up, and that was
I
always
know
lovely.
it
Josh
is.
was a
And
former student of mine.
yes, we have known each other for over 2 decades now, which is just wild to say. So, yeah, it's super fun to. It's one of the things I've enjoyed being in this role is bringing back some old friends and colleagues that are experts in different spaces and getting to catch up with them and share the podcast with them. So, super fun. So, thank you again for being here. And for those people listening, Kaylin, that haven't known you for over 2 decades, tell us a little bit about yourself and maybe a little about your practice side and your passion for what you do.
Yeah, so I have been a pediatric pharmacist for over 20 years, like Josh said, and I'm currently a clinical professor at the University of Florida College of Pharmacy, and I have a clinical practice site for part of the time at UF Health Shands here in Gainesville, Florida. And I recently transitioned over. I've always been very interested in infectious diseases. I have a background in microbiology, and I've always been really interested in pediatric patients. And they get a lot of infections and come to the hospital. So I've recently transitioned into a practice site where I do a lot more with the pediatric infectious diseases team and antimicrobial stewardship. So that's very exciting. So when I got this information about this podcast, it's helpful because I also am very involved and passionate about pharmacy residency training. And literally working on a project right now with my resident about the RSV monoclonal antibody and its use last year. So this is very timely.
Yeah, that's great. That's great. Yeah, I know that you have, when we were talking about RSV, you were one of the first people that popped in my head because I know you've been in that space and you're super passionate. And I always actually forget that you have your microbiology degree. So that's a good reminder for me as well. So, but yes, thank you again. I know this is taking time out of your schedule. You're obviously still in your office and giving us your time. So thank you so much. We really appreciate it. So as you all know, our listeners out there are very aware of the fact that we're coming up on the respiratory virus season, right? So the fall is when we start seeing a lot of those things peak. COVID, flu, RSV has been really in kind of pushed towards us recently with a lot of information. And we just really kind of wanted to come together today and just kind of reset the stage and make sure everybody's on the same level and understanding what RSV is and who it infects and why it's important that we are fighting against it in addition to flu and COVID and other things. So Kaylin, I'll let you kind of spend just a couple minutes just reminding us what RSV is. I mentioned what it stood for earlier, but go ahead and tell us again and just kind of tell us its significance in the different populations that we're worried about here with our peds and our older patients.
Yeah, so RSV or respiratory syncytial virus, so say that five times really fast. So we'll refer to it as RSV.
Yes.
Is a very, very, very common respiratory infection, and it usually does mostly impact our younger patient population, our older patient population, although anybody can get it at any time, really. And it most of the time is just one of the viruses that causes kind of common cold symptoms. Now, if you are very young or very old, it can take, it can take space up in your lower lungs. And so really the majority of patients who get severe RSV infection in the younger population, like the pediatric patient population, they get what's called RSV bronchiolitis, where it infects your bronchioles, and does result in hospitalization, some problems with, future comorbidities later in life and those kinds of things, and could even progress to RSV pneumonia.
Mm.
In older adults, that's typically what we're seeing is more like it would cause a secondary bacterial pneumonia, and again, could be associated with more hospitalizations, more severe respiratory complications from it. So
Right. And I mean, death is in the mix as well, right? I mean,
for
it
sure,
can, it
for sure.
actually can
Mhm.
lead to death, especially in the extreme vulnerable populations or those that are already immunocompromised for some reason. So I think it's important to remember here that while we focus on RSV in those vulnerable populations, usually the younger and the older, it is really like it's out there and everyone is catching it, right? It's contagious for
Mhm.
everyone. So it's not like we're immune to it. It's just our bodies are in a way to fight it off. We're more capable of fighting it off, right?
Mhm. Yeah.
Yeah.
Yeah,
Um,
two out
so
of every three infants will get this before they turn like 1 year old. So it's like very common.
it's very common. Yep.
Yeah.
Yep. And so and out of those two of three, I mean, you don't have to have specific data here, but like the majority of those get over it, or the
Mhm.
so it's really just this special population that is really affected by it in some form for whatever reason. Are we seeing like when do we see it become more of a problem in those pediatric patients? Like, do they have other things going on that make it more of a risk factor for them?
Yeah, definitely exposure earlier on. So,
Mm,
those babies under like 3 months old tend to be the
hmm.
ones that would probably get it from, somewhere in the environment, somebody that they've been around. And those tend to be the ones that just can't handle it as much and be treated as an outpatient. All
Got
the
it.
pediatricians that I work with, it kind of follows this curve, and there's like a peak day of disease, and if they can get over that usually as an outpatient, they're usually fine,
Mm,
but they might get admitted sort of on that peak of symptoms, which is like already by like day 4 or 5.
interesting.
And they've been sort of kind of like circling the drain of needing
Hmm.
some extra, going to the pediatrician and that kind of thing. And then it usually tends to be when, they are having complicated respiratory symptoms like additional wheezing, problems keeping their oxygen saturations up that would make them get admitted. And, the hard part is when they're admitted, it's very resource utilization heavy because there's really no treatment. They kind of just have to sit there. Usually they need supplemental oxygen. They are taking, a hospital bed, and,
Hmm.
they kind of just we have to make sure that we are continuing to feed them and make sure that their oxygen is
Hmm.
good and all that stuff. And then,
Hmm.
they might stay for 4 or 5 days. So,
Yeah, so that's interesting to note. So that there's really no treatment per se. It's really supportive care,
supportive care.
basically. Yeah. And so the other thing I would assume too, preemies are probably at a higher
Hmm.
risk because just of developmental issues and things like that. So
Hmm.
yeah.
Hmm.
Okay, so um, and then I know that your specialty area is peds, and but obviously we see the same sort of I guess what's the word I'm looking for? Same sort of storyline here in our elderly population, those that are more vulnerable, those that have other comorbidities, potentially other respiratory or breathing issues, because it would be harder for them to get over the common cold, as we would say. And so, again, same sort of thing, no treatment. It's really just, again, supportive care. And, you know, we all know that the hospital is not a place where you want to be to really get better because you're
Right.
usually going to catch something else, right?
Right.
And
Right.
so
Yeah.
that is the problem, and that's why you're saying is that typically that's why it leads to pneumonia or something is because they're catching another bacterial infection. So yeah. Um, so I think one of the big
Can I
things that
say
I
one
want
more
to,
thing? We do
yes,
have,
please.
yeah, we do have really good detection now, because we do have respiratory viral panels, which can detect for it pretty quickly. So that's helpful because at least you would know what it is before we really, we'd have to wait a little while.
Oh,
But
sure.
usually we know, even if they come to the emergency room or something like that. So that's been helpful over the past several years. We've had that, but
Is
that's
that a
nice.
tip? Is that like if they're having a respiratory issue, that's like a test or a panel you would run to see?
Hmm.
Wow,
Hmm.
that's really
In
cool.
adults
Okay.
or, yeah, in anybody really.
Yeah, yeah. Okay, very interesting. Thank you. So one thing that I think I really want to focus on for today's episode, and I feel like there's still a lot of confusion out there because rightfully so, there's different kind of products on the market, is there are vaccines and there are monoclonal antibodies. And remind us what are the differences there? What does that mean? Why are there two different categories? Obviously, they're administered differently and they're for different reasons, but if you can just kind of shed some light on that, because I think there's what we often just say is RSV prevention or RSV treatment, which are really the treatment one is not an appropriate term because we're not really treating it, right?
Mhm.
So let's talk a little bit about the differences there, if you don't mind.
Yeah, for sure. And I want to give some historical perspective. We have had a RSV monoclonal antibody for many years. It was
Hmm.
called palivizumab, and it was for a certain subset of patients. And those were those patients who are most likely to result in having severe RSV disease or hospitalization. So those premature infants, the ones with chronic lung disease on home oxygen, congenital heart disease, severely immunocompromised. But it was only a subset of patients. You had to qualify for that. It
Mm,
was monthly shots throughout the RSV season. So that's been, since for like 25 years or something like that. So we've always had that. I
right.
think the big new thing is the RSV vaccines that are out
Hmm.
now.
Right.
And
Right.
then on top of that, also new monoclonal antibodies that have really changed the CDC recommendations on birth doses of vaccinations, which is like I haven't seen that since I've been in practice. So that's
Hmm.
really revolutionary that they're recommending something that can be given at birth to help protect against RSV. So
Hmm.
let me start with the vaccines.
Yes.
There's a vaccine available for older adults, 60 and up, and that should be given once. And it will protect against RSV. It's really important, I think, as pharmacists to recognize that we have a lot of older adults who are interacting with their
Hmm.
grandchildren, and
Hmm.
they a lot of times are sometimes the primary caregivers for working parents and stuff like
Hmm.
that. So
Yep.
again, those would be great points to kind of bring about of why it would be important to get this vaccine.
Yes.
There is a separate vaccine, so they're under two different brand names and have two different, a little bit of different mechanisms. That is for pregnant women who are close to delivery during the RSV season. So about a month before the RSV season through, the prior month of RSV season. So like you mentioned, it's usually like in the fall months, so like
Hmm.
October to March. So
Okay.
from September to February, pregnant women should get this a little bit closer to birth. Um, so those are the two vaccines. So
Okay.
the vaccine for older adults is not the same vaccine for pregnant mothers.
Correct. Yes. And I think something else that you said, and I want to highlight as well, again, is the importance of noting that this is not an annual vaccine like flu, correct? It is
Mm-hmm.
currently a one and done sort of
Mm-hmm.
vaccine. Okay.
Mm-hmm.
And I think that's where a lot of the confusion is as well. We have, let's face it, vaccine fatigue, like
Mm-hmm.
every year you've got to get this one. And now we're saying you need to get a COVID. And now here's another one. So I think it's really important to note that as we're talking with patients and as we're recommending this for certain populations, it's important to note that, first of all, have you already had one? Like, did you have it last year or whatever? Because it's a one-time vaccine currently. I love your highlighted point on grandparents are typically um, at higher risk because they're involved a lot with younger children. And we all know that those younger children bring home a lot of things from daycare and school and all that good stuff.
Mm-hmm.
And so if our patients are in any sort of compromised position, they're going to certainly be more apt to pick up that common cold and potentially not be able to overcome it. So I think that's a great talking point. That's a really key thing as we're, looking and having those discussions with our patients in the pharmacy. Those are the ones that we should be targeting as at risk, I guess.
Mm-hmm.
Um, and so again, just to reiterate what Kaylin mentioned, also it's important to note that the vaccine for pregnant mothers is different than the vaccines that are used in our older population. And on that note, when we're talking about the pregnant vaccine, the pregnant woman vaccine, Kaylin, is that does that then mean that the baby does not have to receive anything after birth, or is this passing in the placenta, or are we okay? Okay,
Yes, yes.
okay,
I should say the older vaccine, the vaccine for older adults, I think there's like a small subset of patients that could get a second dose
okay,
if they have
okay.
certain risk factors, but
Noted.
most of the time, most people would just get one and be done.
Okay, noted.
Same thing, you would need to pregnant mothers would need to get this with every pregnancy because yes, it protects the baby during that first part of, the RSV season. That's why we want to give it during, like right before the RSV season starts
Hmm.
and sort of
Right.
like close to delivery.
Right, right. Okay, that makes sense. Okay, so then let's go to the monoclonal antibodies. So
Mhm.
these are going to be in the pediatric population, and
Mhm.
you mentioned how I remember back when I first graduated, I kind of moonlighted at a at-home pharmacy care place, and uh, back when I had so much energy because my days off, I would go work somewhere else. Like, those were the days, right?
Right.
Um, but anyway, I remember the monthly RSV, and I remember that that was something fairly new for me. I didn't feel like I learned a ton about it in school, and so I remembered RSV, but not like how often is it, and the fact that it's every month and it's during the season and whatever. And I remember packaging and approving and verifying those doses to send out and whatever. So yes, so I remember that that's been around for a while. So let's go back and talk about how that's different now. Let's look at
Yeah.
what the new landscape is for monoclonals.
Yeah. So there was one that was approved in 2023 called Nirsevimab, and it's probably the one that's been used the most to date since
Okay.
2023. It was in such high demand that the supply didn't even keep up with it. So last
Mm,
RSV, like the 2023-2024 season, not as many babies got it, but then they fixed the supply problems. And so for 2024, 2025, and moving forward, we know we have significant supply. But with the 2023 recommendations from the CDC, the annual recommendations, that's when they changed and added that to be given as a birth dose for anybody whose mother did not get the RSV vaccine um, within 14 days of delivery.
got it.
So if you were a pregnant mother and you decided not to get the vaccine, then we could give the baby the monoclonal antibody, which also is one and done unless you have some underlying risk factors, and then you might get a second one during your second RSV season.
Okay.
Just this year, there's a new one called clesrovimab that has just been approved. It has not been added to the vaccine schedule, but the ACIP that just did meet did recommend it as an alternative to nirsevimab. So you could use either one of those. And
Okay.
those are monoclonal antibodies that would help your body not let the RSV vaccine get down into the bronchioles and get to your epithelial cells, and it would provide passive immunity for the RSV season.
Got it. And so again, just reiterating the fact that you mentioned there was a subset of certain high at risk that would get another dose, but this is also a within birth of 14 days or so, and it's just that one time. Like it's no longer monthly during the season. It's no longer like every year when this comes back up or whatever. Okay.
Mm-hmm.
Okay.
Yeah.
And what does it matter? So in the sense that it matters when the mother is about to give birth, does it matter when the child is born? Like, are we only dosing for the monoclonal antibodies during the season? Like, so if you're born in June, are you recommended to get this, or is it for everyone? Does that make sense?
Yes. So it should be during the months of October to March. Now, knowing that the southern hemisphere, so Florida, where I live, is a little bit different.
Hmm.
Puerto Rico, Guam, Hawaii, follow your local guidance because they may have some different seasons. So RSV
Mm,
season is actually already started here in Florida in
got it.
September. So follow your local guidance if that has kind of a different, and the ACIP guidelines are, do provide that variability that like if you live in an area where it's a little bit different, follow those guidelines.
Got it. Got
Um,
it. Good to know.
and but that being said, if you are born from April to September, there is a recommendation that you could get this
Hmm.
once RSV season comes around.
Got it. So
Yeah.
it almost becomes then a clinical decision between parents and providers and so forth. Got
Yeah.
it. Okay.
Yes. It's
Okay.
recommended that it would still be available, but yeah.
Okay. Okay. Makes sense. Okay. So I think that's super helpful. I think it reminds us that we can't really collectively attach a label to this as RSV prevention. I mean, I think because it's very different, right? And we're looking at different populations and different special populations and subsets and times of the year and all that kind of stuff. So I think
Mhm.
it's really important to just kind of break that down and understand that when we're talking about hey, let's prevent RSV, there's like multiple modalities, right? So we have to be sure we're talking about the same thing. So one thing I always like to do with the podcast, Kaylin, is really kind of talk about what are the opportunities for pharmacists. So now
Yeah.
we know kind of this foundational information. We're all on the same page. So what can we do as pharmacists, regardless of our practice setting? I know that if it's a Kaylin out there, it's very different because you're in
Mhm.
peds and you're used to be in the NICU and that kind of thing. But if we're in the community or if we're in an AmCare side or if we're at the VA or whatever, like what sort of things can we do in general as a pharmacist? So the first thing I'd like to talk about is identifying eligible patients, right? So I think
Mhm.
that's key. So
Mhm.
any pointers or tidbits there or reminders?
Yeah, I definitely think it would be easier in most settings because we do have a lot of pharmacists in ambulatory care settings where they're taking care of, older patients, and
Hmm.
also in the community, you're going to be
Hmm.
engaging with those patients a lot, to educate that there is a new RSV vaccine, ask if they've
Hmm.
gotten it, ask if they've gotten information from their doctor. If you can, order it and give it under protocols, then definitely we should be trying to do those initiatives. I know there are some pharmacies that can give it and do give it. Um, and then, I think that the second space would be anybody who you are interacting with who is pregnant.
Right.
It would
Hmm.
be really important to also educate that they should talk to their caregivers about that,
Right. Right.
and ask about that. And, we can always still be very, I think we need to be in the educational space, right? That these
Yeah,
things
for
are out
sure.
there.
Yeah.
Um,
Well, and
and we do
especially
have a
since
lot
there's
of
an
pediatric, oh, I'm sorry. Yeah.
no, go ahead. Go
Okay,
ahead.
I was gonna say, we do actually have a lot of pharmacists who specialize in, mostly specialized in neonatal care that have also kind of embraced women's health, which has been really great to see,
Hmm.
that growth. And we do have pharmacists who are specialized in women's health. So obviously, I'm not talking to you guys that would be specializing in women's health and who would be doing a lot more in that area. But if you have an opportunity to work in an inpatient setting where you're working with pregnant patients, for sure discussing that. And then, again, on the flip side with the monoclonal antibodies, trying to make sure that we're getting, doing birth doses is probably going to be, inpatient, and trying to
Hmm.
really figure out the ways to do those, from the pharmacy side is kind of what we're
Yeah.
navigating right now.
Well, and also just, as you mentioned, we are the medication experts. We should be in that space of educating and providing the right information to make an informed decision. And, even if you are talking with a pregnant mother and, birth is around the corner and you've talked about that option, also discussing, what are the options for monoclonal antibodies and, what does that look like? And
Mhm.
especially if the person's not going to give birth at the right time, then maybe it's something to say, hey, it's something to still consider if, especially if within the first few months, if it's a preemie or if you understand or realize that they're having some other respiratory conditions or they've been hospitalized with asthma or something like that, that might be another risk or reason to kind of look at that. So I think it's really important, as you mentioned, to have those conversations with those patients because we assume they're getting it somewhere else, but they may not be. They may not be
Mhm.
having this conversation somewhere else. Um, so another thing that I think is important and along the same line, is that we're educating not only our patients, but the other providers and other caregivers that we're collaborating with. So any tips or tricks there that you can share that I know sometimes it's difficult to tell other providers what to do or what should be done, but you're a seasoned professional here. So if there's any tips or tricks in that space, I think we'd all welcome those.
Yeah, and I think one of the things we learned from last year was we were getting these babies that were born and we did not have any information from the mother because the mother, gave birth so imminently or something like that. And so there were, we couldn't really give the birth dose because we didn't know if the mother got it or didn't get it. And sometimes if you
Mm,
work in a hospital where, you might work in a children's hospital and the mother's in a totally different hospital. So there's a little bit of a time delay
mm,
there. So ensuring, especially babies that are born, you have to kind of understand what happened before they were born as well. And so,
yep,
talking to providers about, if you're talking, about pediatric patients or neonatal patients, like, well, where's the birth records on the mother's, exposure and all those kinds of things is something important. And I think, they usually have really pretty good protocols, but making sure to add in, like, now we have to know if they got the RSV
yeah,
vaccine, right?
yeah.
And then I think the most confusing thing is the timeline.
Hmm.
And we have the, most places would have the vaccine schedule sort of up and around and in a lot of parts of the hospital to make sure we know what we're giving and stuff like that. But I think knowing what the months is, and so there
Hmm.
are some resources online that
Hmm.
have a good timeline, like it's April, here's what you would do. It's
Mm,
October, here's what you would do for the
mm,
mother and for the baby.
love
So
that. Yeah,
yeah, yeah. So I think being because they'll turn to us and be like, wait, it's
sure.
September. Are we doing it, not doing
Hmm. Yeah.
it?
So to be prepared and stay up to date
Yeah.
on that and maybe when you have some time to twiddle your thumbs like we all do as pharmacists, go ahead and research and find those resources because I think that's great. That's great information to kind of have, like you said. And again, people do often turn to the pharmacist for answers about anything to do with medication. So it's important to kind of be prepared for that. So yeah.
And I have fully made this mistake too, where I have said we need to make sure that the baby gets the RSV vaccine, and they do not get the RSV vaccine; they get RSV monoclonal antibody. But I
Yep.
think also discussing the differences between the RSV vaccine and
Yeah.
monoclonal antibody
Yeah.
um, is something we need to make sure, just like language type things, we
For
need to.
sure.
I'm like, oh wait, no, it's not a vaccine. Sorry,
Yeah, no, you're
but it's in
exactly
the
right.
vaccine
And
schedule, so it's just comes off the tongue.
so it makes sense that it would be. Yeah, I know. I know. Yep. And that's what I was saying earlier is I feel like there's just still a lot of confusion as to what are these and what should they be called? And you're right. I find myself literally, I remember when I first did this topic, I labeled the initial file as RSV treatment. And then I
Right,
looked back at it later and I was like, that's not what this is. Like, we're not going to be talking about treatment. That is no such thing?
right.
So yeah, so I think it's really important to verbiage and to make sure that we're all saying the same thing on the same page. So, and then we already talked about this, but it is going to peak, I guess, for the most part in the respiratory season. We already have flu and COVID and other things that are happening in that space, but it's a great time to just go ahead and roll that into the whole discussion, talk about it. I would just imagine too that if the mother was not vaccinated, they weren't talked to about it, didn't have the conversation or whatever, they're probably also going to be confused and want more information when they're asked about it in the hospital of do you want
Mhm.
to, give this monoclonal antibody to your child? And so
Mhm.
again, that could be additional opportunities for us to educate and to provide some guidance and everything there. So um, yeah, so and then some challenges. Unfortunately, things don't always come with a rosy cherry on top, right? So some challenges that I think people are seeing in practice is again, it is confusing. Vaccine versus monoclonal antibody. Which age groups for which one? The fact that there's a vaccine for pregnant women that gets passed to the baby, but yet it's not vaccinating the baby, right? So it's confusing and just making sure that you're up to date on everything and understanding the terminology. And then again, those administration windows, as we've said over and over, it's confusing. It's best just to get a good resource that you appreciate and like and follow it. Um, And then, Kaylin, have you seen any sort of access issues, or are there reimbursement issues, like insurance rejections for these medications? Anything that you've
Mhm.
heard of?
I haven't, and we have given it, so all children should be covered under the Vaccines for Children's, where they get vaccines for no cost. But if you give it in the outpatient setting and you
Mhm.
don't have a separate supply for Vaccines for Children's, which sometimes we wouldn't have set that up already for monoclonal antibodies. We have that set up for a lot of vaccines, but we may not have that set up yet for the monoclonal antibodies.
Sure.
And somebody does have private insurance. We have been able to run it through, and we haven't really seen too many problems. They may have a small copay that they might have to, have to
Sure.
incur. But for the most part, I would say that it should be covered under the Vaccines for
Okay,
Children's.
that's great.
Um,
So
yeah,
really, when we're talking with patients, we're not really trying to overcome any kind of access issues. We're really just educating and trying to make sure everybody understands what's at play and what's at risk. So yeah.
yeah. I think
Okay.
another challenge would be anticipating the supply, just like we do with the flu
Mm,
vaccine every year, right? So if you're
hmm.
not keeping the flu vaccine all year round, which pharmacies can do that, but we may not keep this all year round. And so then
Hmm.
when are you like turning on or off some of the things in the
Sure.
electronic medical record, like, hey, it's flu season. Hey, it's
Flag for
RSV
this.
season.
Hmm.
Are you educating the providers, or the patients about this? So that would be some of the things too that you could set up probably
Yeah.
in your electronic medical records to turn on or off alerts for
Yeah.
nurses, clinicians to discuss at certain visits.
Yeah, and then in your prescription processing system, if you're in a community or AmCare site or specialty pharmacy, making sure that you're only discussing that, like you said, in the height of the season, just like you would, flu and COVID. So yeah. Okay, and then the last thing is, again, just to stay up to date on information, making sure that you're following along with ACIP guidelines and recommendations. And we all know that that has been a little bit of a journey recently, and that's a whole nother discussion. But I think that that can be certainly a challenge, is just to make sure that you're up to date on everything that's being recommended, that's currently on the market, that's listed on the schedules and things like that. So,
Yeah,
um,
like I said, the new one isn't even on there yet, but when you go to that product's website, it says, per the ACIP guidelines, this was just discussed. And we know that there's certain time periods where they meet. And so, I'm sure, again, the schedule has already been set for this year, then they might just put this or this one on
mhm,
there.
yeah,
I didn't even know about it a couple of weeks ago. Somebody was like, "Oh, the new one just came out," and I was like, "Okay, well now I gotta go find out about this and why
yeah,
is it different and how when are we gonna recommend it?"
right, right.
Yeah,
Good to know. Well, that is great. That is all that I have to really cover, Kaylin. But the thing that I always like to do at the end is to wrap it back up with what's our game changer here, and I always pose that back to our guests. So, Kaylin, what's our game changer? What's our big important take-home factor today?
yeah. I think the fact that we have an RSV vaccine for older adults and we have this RSV monoclonal antibody that we're recommending at birth universally is the game changer, and it's
Yeah.
going to hopefully lead to less hospitalizations, less severe complications, and really help our patients, our special populations.
Yeah. And I think, part of the other game changer here is that pharmacists are key, especially to that older population, because we're seeing them all the time, typically, in most settings. If you think of VA, community, AmCare, even inpatient, like the majority of the patients that we see are going to be our older population, and they're usually going to be vulnerable in some sense, if we're seeing them often. So I think it's key again to be up to date, understand the differences, understand what to recommend to what patient, and that there are differences. It's not just a vaccine across the board. It's monoclonal antibodies for pediatrics. There's a vaccine for pregnant patients that can pass to the child, and then there's a vaccine for our older patients. So, yeah, that's super helpful, and I hope that that clears up some confusion. I know it even helps me, even though I prepped for this and everything. I still feel like there's just a lot of confusion around what's the difference and why
Hmm.
why do we call this one thing and that another thing. So
Hmm.
yeah, very helpful. Well, Kaylin, thanks again. Super great to see you. as always, and just really wonderful to have you as our guest today. So thank you for your time.
Thank you. So thankful for this opportunity. I enjoyed
Yeah,
it.
absolutely. If you're a CE Plan subscriber, be sure to claim your CE credit for this episode of Game Changers by logging in at ceimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all next week.